I'm Colleen McQuillan. I've been working with traumatic brain injury for about almost 30 years and find, it's my niche, my love. So we thought it's actually Traumatic Brain Injury Month, for those of you who don't know. So we thought we'd have that topic today. Here's the objectives, which are printed there, so as printed. We're going to just go through it a little bit, what the difference is between traumatic brain injuries, acquired brain injuries. There's a lot of terminology that's used that's pretty synonymous, but there are a few differences. Some of the effects, some of the objective measures, and outcome measures that you can use, and then a little bit about concussions. National Brain Injury Month, so you'll see more, a few things out there about it. A lot to do with, prevention, helmets, seatbelts, all those fun things. A little bit of an overview. Traumatic brain injury is a major cause of death and disability in the U.S. It contributes to more than 30% of all injury deaths. It's considered the silent epidemic because most people don't talk about it. It happens, people have a traumatic brain injury via a car accident or ski accident or whatever, and then end up in the hospital, and then that's kind of the last you hear. So it's really out there, but unless you deal with it personally, might not know too much about it. What is a TBI? It's a disruption of normal function of the brain caused by a bump, blow, jolt, or a penetrating wound to the head. There's a severity from very mild to very severe. And a huge wide range of effects from even a mild brain injury that we'll go over. Most TBIs that occur, though, are mild TBIs and are considered concussions. So that's the terminology that you'll hear. The National Head Injury Foundation, which is a foundation that I belong to for, since I've been doing traumatic brain injury, they define TBI as an insult to the brain, not degenerative or congenital in nature, but caused by an external force that may produce a diminished or altered state of consciousness, which results in an impairment of cognitive abilities or physical functions. It can also result in the disturbance of behavioral or emotional functioning. These impairments may be either temporary or permanent and cause partial or total functional disability or psychosocial maladjustment. So that's like just about everything. They're not really leaving anything out. So from an incidence standpoint, they've determined that 23 seconds, every 23 seconds somebody sustains a traumatic brain injury. 1.4 million occur every year, 4% occur in death, 17% have hospitalization, 79% have either an emergency room or emergency department visit. More than 50,000 die every year as a result of a traumatic brain injury, and not necessarily at the time of impact. It could be later on as they're throughout that illness. And greater than half, 59%, occur in males over females. Usually 65 years and older range, you're going to get the highest hospitalization rates. Falls were the leading cause of death for persons over 65 who suffered a traumatic brain injury, but the highest emergency room visits are for 0 to 4. Mostly because it's the emergency room visits, a lot of those then leave. It's a visit and then they go back home, versus the older population, they end up staying. The falls were the leading cause of TBI-related emergency room visits for all groups except for 15 to 24, which they determined assaults were the leading cause of traumatic brain injury. Moving vehicle accidents were the leading cause for persons for hospitalization for that 15 to 44-year-old group. And now you'll see it as, they don't term it MVA, they MVC, which is motor vehicle crash. I'm not sure why the terminology has changed, but you'll see that in the literature. An acquired brain injury. The association defined an acquired brain injury, which you'll see as ABI, as an injury that occurs after birth, not hereditary, not congenital, or degenerative. This includes TBIs and injuries caused by insults, internal insults to the brain. And some of those would be called non-traumatic, where there wasn't a blow, wasn't an accident. So here's a little graph to see how they kind of spread it out. Your non-traumatics are going to be things like anoxia, like status, like had a heart attack, lack of oxygen to the brain, near drowning, infections, your encephalitises. They kind of lump strokes in there, as well as tumors and metabolic disorders. Then your traumatic brain injury, you can have an open and a closed. Your open injuries are anytime the skull's been actually penetrated. So it could be assault, fall, any type of accident, abuse, surgery. And then you have the closed head injury, which is more of an internal pressure issue or shearing injury, which can occur from an assault, sort of a shaken baby type of thing would be a closed head injury. Falls, again, actually where you might have a subdural hematoma, but no surgery was required. So the skull remained intact. You're going to see a lot, I see a lot more of my elderly population with traumatic brain injuries than I've ever seen before. And the two biggest factors are falls with these individuals because of balance, and they're all on, they all have AFib. And if you're on AFib, you're on an anticoagulant. So they just have to tap their head practically, and that will cause a bleed with being anticoagulant. So it's a big part of my population that I see right now.
Do you think it's more frequently diagnosed than it used to be?
No, I think just patients are living longer, and they're just, balance is becoming a bigger issue, and I think they're surviving their AFib longer because they can be treated. So it ends up, if they don't die of something regarding the AFib because that's managed, so they're not having the stroke, but then they're having their falls, and it's really causing, quite a calamity for them, unfortunately. Again, some of the causes, you can do anything from, traumatic, tumors, toxic exposures to a lot of substance abuse. The heroin has been a big issue in the suburbs around here, and we've had several patients who've come in with a head injury because of a heroin overdose. Major, issues to treat. Again, you can do like your metabolic disorders, diabetic coma, liver disorders, hypoxias, anoxias. Your traumatic brain injuries, again, are going to be more falls, gunshot wounds, motor vehicle crashes, blows, the explosion and blasts, a lot of, from the Gulf War to the Afghanistan, what's going on there. The military is seeing a lot of blast issues with traumatic brain injuries. We're not at Marion Joy seeing a whole lot of those individuals. They're staying more into the veteran system. Penetrating injuries and then shaken baby. So again, here's just a graph on kind of how many and what. So the falls are the biggest population. And then motor vehicle kind of accidents, and then being struck by something, whether it's an individual, a club, whatever, and then assault. So we can classify brain injuries, traumatic brain injuries, as mild, moderate, and severe. 80% are mild, so those are your concussions. 10 to 30% are more of your moderate, and 5 to 25% are severe. And this is how they classify them. It's not a hard, fast rule, but it's a pretty good way of pigeoning these individuals in the right hole. So your mild brain injuries, your concussions, they might have a loss of consciousness from 0 to 30 minutes. They're going to look at their Glasgow Coma Scale, which we'll talk about in a minute, and that's going to be between a 13 and a 15 score. And then their post-traumatic amnesia is usually less than 24 hours. More into the moderate category, a little bit longer, 20 to 30 minutes to up to 24 hours of loss of consciousness. Your Glasgow scale is going to be 9 to 12. Your post-traumatic amnesia will be greater than 1 day, but less than 7. In your severes, loss of consciousness greater than 24 hours. Your Glasgow scale could be 3 to 8, and your post-traumatic amnesia is greater than 7 days. Now, they don't all have to have all of these. There's many of my patients who will have severe traumatic brain injuries that won't have post-traumatic amnesia for 7 days. But then there are others that will. Or your Glasgow might be a little better than that. So, but you kind of lump it in and you put, when you all the things together, and that's how they try and organize it. You can have folks who have what they call a moderate TBI that can have still pretty severe deficits. So you kind of have to look at them in that vein so that it's like, well, it's usually we classify whether I classify more as a mild who have minimal deficits to more of a severe where they're if they're having more deficits. The moderates are just kind of in the middle. So they look at the Glasgow Coma Scale. Is everybody familiar with it? Seen it? So it's just a tool to assess coma and impaired consciousness. It's just going to measure eye response, verbal response, and a motor response. And then you get a total score. So they add those up. And they do that usually at the scene or in the emergency room or early on after surgery and stuff, that they'll use that scale. Once they get to rehab to our unit, we never do that. But I will look at that at the chart to find out when I see the report. It's like, okay, what did they come in at? The lower the score, obviously, the more damage I'm expecting. The higher the score, it's like, okay, well, they may still have some significant injuries, but not necessarily, their brain injury might not be as severe. So we talk a little bit about mechanism of injury, what's going on really with the brain. So you can have direct trauma right to the brain tissue. You can have that axonal injury where that, coup contra coup, where that brain is shaking in that skull, and that's what's causing your damage. Swelling from either hematomas or hydrocephalus. So either you got too much fluid pressing or you've got blood creating that pressure in the brain. That's causing damage to the brain because, the skull's holding it all in place. So unless they do a craniotomy to open up that skull to relieve that pressure, you're going to end up with significant pressure going into your brain. The anoxias and hypoxias, so lack of oxygen or decreased oxygen to the brain, either near drowning, cardiac arrest, stuff like that. And then your hemorrhages. There's 2 different types of brain injury that we look at. There's a primary brain damage and there's a secondary. So your primary brain damage occurs at the time of impact or injury. So what happens immediately to the brain? So that object that penetrates, your skull fracture, a blood clot, for example, any of that, or that new bleed, that's your primary brain damage. And then your secondary is what occurs sort of over time over that trauma. So you have increased swelling, increased intracranial pressure, or seizure just, that occur. So that adds another insult to the brain. So that's adding secondary damage to an already damaged brain tissue. It doesn't really matter when it comes to treating them. What really matters is if you know that it's like, well, we've had this one injury, we've had that secondary incidents that you can see when you're reading a report that they've had these, that you can expect probably more deficits, probably longer recovery time because, you've added that additional insult. So types of severe brain injuries. Closed head injury we talked about. It's going to be an injury that's caused by movement to the brain within the skull. It can be caused by a fall, motor vehicle accident, being struck by an item or an object or a person. You can also have a penetrating injury. That's when a foreign object enters the brain. So usually that's a gunshot wound or some other sharp object, golf club or whatever, somebody striking you in the head. That's going to be your penetrating. So effects. We talked about how many effects there are. They're very vast. So I broke them down into these 6 categories. So you've got cognitive effects, motor effects, sensory, emotional, medical, and then communication and language. So those are kind of your broad effects that you would see with somebody with a brain injury. You may have 2, you may have all 6, you may just have 1, you may have 5. I mean, I've had every combination I think I can think of. So the cognitive effects, what you're going to see, patients are going to have impaired attention and concentration. They're going to have memory deficits, so either short-term, new learning, new memory, that kind of stuff. Impaired problem solving. They might be able to do something, but they can't figure out a task. Executive functioning, being able to plan and organize an activity, plan it, and then follow through, and then circle back around and say, okay, did I put it all together? You know, to be able to like check their work. Like doing a checkbook is an executive function. Lots of issues with that. And then decreased initiation. They may not be able to get anything started. Then it's just like until you kind of start them on that path, they're just going to sit there, deer in the headlights kind of look. And so those are all the things that are, could be affecting your patient. Communication issues, your aphasias, your dysarthrias, having that weakness, and their oral apraxias, not being able to coordinate the muscles or whatever to talk. And your speech therapists are going to handle most of those. Your motor-wise, you've got everything from a weakness to a paresis. You can have a quadriparetic, paraparetic, tetra, you name it. Usually it's quadriparetic or a paraparesis for the most part. Depends on the area in the brain that was compromised. Spasticity, so that increased muscle tone, is really common with patients with traumatic brain injury. Or you might have a complete flaccidity where there's absolutely no motor tone occurring in a limb or 2 limbs. Your apraxia is not being able to get something started. That's that initiation issue. The ataxia, that incoordinated movement. They can move, but they can't put it all together and move in a coordinated manner. Or it could just be a coordination issue where it's more of a limb, fine motor coordination. So it could be, a smaller degree or a greater. Balance is a huge thing that we deal with because of all of those issues. They have weakness, they have spasticity, they have coordination issues, and then try and put it all together, and that's balance. And it could be everything from a sitting balance to standing to more of a dynamic balance that they would have. And then the dysphasias, where they have the weakness in the swallowing in the throat musculature, so they're not able to take, say, thin liquids or whole foods because they can't manage that and swallow that safely. Sensory, you're going to get their visual system. You might have a hemianopsia. You might have a double or blurred vision. We're seeing a lot more, we're working with a lot more of the visual deficits because it's impacting so much. We're fortunate enough at Marion Joy to have a neuro-ophthalmologist that comes in once a week. And she can go through a full assessment on a patient and tell us what it is we need to do, from whether it's eye exercises or prism glasses or different kinds of glasses and stuff like that, to be able to help us work with these individuals to make our treatments more successful. Vestibular dysfunction is huge. I don't know what we did 10 years ago because it had to have been there, but we didn't treat it. We never thought about it. But right now, I can't tell you how many of my patients who, especially these elderly who fall down, hit the back of their head, need to go through a Dix Hall Pike, needs to go through all this maneuvering because their vestibular system is, is all messed up because of that hard blow, that hard fall. But it's something that we're seeing a lot more of, and we're able to treat it.
And like with the concussions.
Oh, the concussions, yeah, is a huge group of that. You don't have to fall with the concussion, but it knocks all those little crystals right out of place. The tactile, some of these folks, will have a limited sensation, but they also have a hyper pain sensation. So everything, things that you might feel uncomfortable to you or pain, somewhat painful for you, is extremely painful to them. They just have that heightened awareness of it, to pain or even to light touch. So they're very sensitive, when you're trying to move them, or do anything from range of motion to transferring because everything hurts. And not to mention that most likely if it was a traumatic injury, there's probably some soft tissue injuries going on as well, because you can't go through a car accident and hurt your head that bad and probably not have a few soft tissue injuries somewhere along the line, or a fall. A lot of the elderly who fall down, their shoulder, hip, all kinds of stuff. And it's when they're as confused as they are in their memories, but they don't remember why it hurts, and they can't explain to you that it's like, oh yeah, when I fell, I hit my hip. If they didn't break anything, you might not even see the bruising any longer. You might if they're on Coumadin, but they don't realize that it's like, oh, that this is why, things are so hard. And then some olfactory, a lot of brain injury patients who've had a major brain injury don't have the sense of smell or the sense of taste. It's kind of a wacky thing. And we don't realize that till way down the road, because they don't even realize it's missing. But a lot of them don't want to eat, and then we're giving them food that is probably not, is a lot blander than what they're used to. So we don't even look at that right away. We should, but it's one of those systems that you're like, okay, But I'm noticing now we use a particular wipe to wipe down all of our mats after each patient. And I've had a number of them are really sensitive to that smell, that I was really surprised, because it was like, I hadn't thought about it, and they're just like, oh, what is that? And you're like, oh. So I'm becoming a little more aware. Emotional issues. Agitation is probably the big one that you think about. These patients do not have any control of their emotions. So things that bother them can really set them off very easily. Depression's a huge one. They don't, they're trying to figure out what's going on with my life from here. So it's very easily, they can sink into a depression very quickly. We're in acute rehab, we're really monitor that closely, because it makes a huge difference in how successful we are in our treatment. Anxiety is a huge problem, and 90% of it, these individuals were anxious people before. So throw on a brain injury on top of that, and then they're really anxious. So you want to come in and move them or do something, and they don't know who you are, why they're there, so their anxiety level really escalates. Confusion is a huge one, obviously. Most of these individuals, things they're not remembering what's going on, they don't know what's going on, their post-traumatic amnesia could be kicking, is part of that. So they aren't aware of their surroundings very well, so there's a lot of confusion. One of the things we're dealing with right now is with all the elderly population that keep falling down. They've already had some issues with dementia or Alzheimer's. So throw a brain injury on top of somebody who's already slipping down that slippery slope really could impact your treatment or their recovery, because trying to get them to, understand why you're doing what you're doing, buy into what you're going to do, and as well as being able to learn some of the things you're trying to teach them. Personality changes. I don't see them as much in acute rehab because not enough's really gone on, but afterwards in an outpatient, post-acute stuff that, family members will tell you that's like, they're just not the same, they're not the same person. Some of their, if they were anxious before, they're more anxious. If they were one of those people that got easily frustrated or angry, that seems to be, always at the surface. Somebody who is kind of childlike will really can kind of get back, more into those emotions than they were before. So you'll see that. There's a huge restlessness. They're busy. They just can't. They're not comfortable. They don't know what to do. So they're moving around a lot. And then the affect changes. Some of them are just not. It's hard to get them to smile. Some of them, cry all the time. It's hard to, you'll see that they just don't, they kind of that deer in the headlights look. I'm trying to get them to, at least have some sort of feeling, at least when they cry or laugh, that you're like, okay, at least we're exploring a few feelings. It takes a while sometimes to see those. Medical issues, consciousness, obviously. the most severe of severes are going to be in that persistent vegetative state. Not necessarily in a full coma where eyes are closed, nothing's happening, eyes are open. They may be able to respond a little bit to their environment, watch somebody or watch something move across the room, might be able to squeeze a hand, but really not much else is going on. So, I mean, we've all heard of, famous people that have, they'll talk about being in a persistent vegetative state. They're just really not gonna, after even, months and months of therapy, really have not been able to recover. Seizures is a big problem. Once you've had an insult to the brain, it kind of messes with its electrical system. So that new onset of seizure, if they've had one, that's also causing, some increased damage possibly. And then the medication, because they're so at risk for seizures, I'll put them on a prophylactic seizure medication. That dampens down how your brain works. If you've known anybody who's epileptic and they get on a new seizure med or they have to change their med, they feel groggy, they feel, it's just like they're not sharp, they're in a fog. Well, put a brain injury patient with, give them some, Keppra or Depakote or something like that, you're also going to have the same effect. So you have to, consider that when you're, working with these folks and figuring out, okay, they're progressing or not, getting some of that balanced. Headaches is a big one, mostly for, your concussions. Post-surgical ones, they may have a big crani scar and whatever, but they don't have a whole lot of headaches sometimes. It's really kind of amazing that some of them don't have more. The falls, they'll have a little bit more. Comorbidities, the sky's the limit. The older they are, the more they have. And then all the other injuries that go along with it. So not only are you dealing with somebody who's got cognitive kinds of deficits, but they might be non-weight bearing on one limb and non-weight bearing on the opposite arm, and so you're like, okay, and I'm supposed to teach about sit up, and they don't know that this doesn't work, kind of thing. So it's that's always another little treat that you get when you have a traumatic brain injury. You're like, well, what else isn't functioning? Your treatment course, obviously you got your acute care. They're going to do emergency room is what's going to happen first, obviously, and then getting them stabilized in acute care. Anymore, basically they get them stabilized. They will get, we'll see patients once they get into rehab with trach still in, not too often with respirators still on. Some of them are doing the ventilators. We're not seeing too many of those. It's just they can't tolerate enough therapy to be on a ventilator. If they're going to be on a long-term ventilator, then I don't know, maybe. But so far, we're not seeing too many of them at Mary and Joy because it's just, like I said, it's a complexity that makes rehab quite a challenge. But then they'll put in, if they're not able to eat, they'll put in G tubes, PEG tubes to take care of that portion. And then you're going to go through outpatient if they make it that far, whether it's just a traditional outpatient or a day rehab type program or more of a community-based program. Or some of them end up in long-term care because they're just the amount of care that's required. Families can't manage all of that. So what's our role? Well, mostly we look at it as a neuromuscular reeducation. That's going to be our primary role. I mean, obviously there's orthopedic portions to that if they've had orthopedic injuries and whatnot. Your postural control is going to be a big one, getting them back so they can sit up, be up in a chair, standing, getting midline. Any muscle strengthening for muscles that are weak. Range of motion, if there's been loss of range of motion, especially from spasticity, where their joints are not responding, so that we're going to have to keep them in that range available. So as that muscle control comes back, they have their available range. Balance training is a big one, obviously, especially with the post-concussive patient. That seems to be their biggest issue is their balance. And coordination, so getting them to be able to move in a coordinated manner. For those low-level patients, those severe brain injury patients, you may be doing things like sensory stimulation, anything from, using bright, colored balls, something that they'll track. We've gone as far as I don't see too many of them anymore, but we would have a whole host of different kinds of scents that they could smell, because that's a pretty powerful one if their olfactory system's still working, or even taste. giving them a little lemon glycerin swab, letting them smell things like peppermint, stuff like that. Do a lot of casting and splinting. So those folks who are, because of positioning and tonal changes, are losing range, especially you'll see it in their ankle, in their elbow, in their wrist. So we'll do inhibitory and serial casting to help regain some of that stretch on those muscles, so that you can get that range back. So when it's time to stand up, then they can stand. They've got a foot to stand on. Wheelchair seating and positioning is huge. Getting them in their proper wheelchair so that they can sit up, eat, help them do their grooming in the morning. Be more relaxed position, because if you've got somebody in an ill-fitting chair and they're reclined and falling out, you're just increasing that tone. You're not improving it. You're not improving head control. So we're really lucky at Mary and Joy. We have a wheelchair seating and positioning clinic. So we can get some pretty specialized chairs. Like one of the ones we use a lot is called a tilt in space. So those patients that don't have head and trunk control, that can't sit up at a 90-degree angle, we take and tip the chair. We keep them at a 90-degree angle, but we angle the chair so that they may be at a 45-degree angle or whatever, so that they can still maintain the right posture that we want to help decrease their tone, improve their range, and stuff, but yet not fall out of the chair. And then a lot of tolerance to upright, just getting them, whether it's on a tilt table, a standing frame, anything that we can do to get them more used to being upright, whether it's, just even getting their blood pressure, getting their trunk control better, head control, so that they can start looking and at least, seeing their environment and being able to access, treatment strategies. If they're all down here and all folded up, then it's hard to get in there and get any real work done. So when they come to acute rehab, they're up 3 to 6 hours a day max, minimum. We keep them up. We may lay them down here or there to rest, but we do not want them in bed all day. They are dressed, out of bed, out of their room, trying not to. It's not like being in the hospital where somebody just comes to them all the time. A lot of functional retraining obviously is going to go on, because that's what insurance companies and families and everybody else cares about. They want, range of motion and strengthening is good, but if it doesn't add up to function, it really doesn't matter a whole lot to a lot of people. So we are looking very early on, teaching, some way to get these folks to transfer, to do their bed mobility, to try and begin some gait training and progress into barriers. That's a lot of what we spend our day doing when you're doing acute rehab. And teaching them different types of transfers. We've got all kinds, ways to do it so they can get up and move, and so families can eventually get them home and assist them with these transfers. And then balance and coordination is a huge part. Some of the things you need to consider during a PT session with a traumatic brain injury that you might not have to if you were doing somebody maybe with, say stroke or Guillain-Barré or whatever, is because of these cognitive deficits, you have to watch what you're asking them to do, how you're asking them to do it. If you don't keep your instructions simple and minimal, you're going to overwhelm them, because their processing speed might be so slow that by the time you got the second word out, they forgot the first word. So you need to make sure that you are cueing them as best you can with as little verbal possibly as necessary. Demonstration works well. Lot of, I tell my students all the time, no, don't ask, can you do this? Because guess what? They'll just tell you no. And you ask them and they'll tell you. So you want to, and don't, can you do this for me? Well, why are they going to do anything for you? As far as they're concerned, that's kind of a dumb idea. So you need to think about how you ask and what you want, because it comes back. It'll come back to you and you're just like, yeah, I walked right into that. And then they won't, giving choices is a great example, because at least you're going to get them to pick one or the other. Or, you can make some deals. We do that, if you do 3 of these, then we can do that. Then we can rest, or we can do it. And then they kind of you can use that short-term memory deficit to your advantage, because they don't remember that they already did 3. So play that one to your advantage. Initiation issues. Make activities automatic when possible. So if you want somebody to stand up, they're sitting on a mat or on a chair, you don't need to go, it's hard as therapists. We want to say, okay, lean forward, put your hands here. Now you're going to, and then you're going to push, and then you're going to put your hands up here. Okay, by the time you just said lean forward, they've kind of, it's like they don't get it. So if you're just like, okay, let's go, let's get up. And then, if you know they have the motor capability, that automatic, you'll be much more successful getting them to do what you want them to do. Agitation. You have to watch your patients. I mean, you have to read their body language. They'll read yours. Some of them, it's a whole male-female thing. Some of it's just like, I don't want to be here kind of thing. Watch activities that are painful or frustrating. If they find that they're hard, they don't want to do them, and they're going to get mad. They're going to get frustrated because it's like they know they can, and if they've got any even glimmer of insight, they're going to be like, yeah, I'm not going to show you that I can't do that. That's what their brain's kind of going through. Or if it hurts, if you've got somebody who's lower level, non-communicative, and got some tone in their arm and in their shoulder, and you're trying to range that, and it hurts, they don't care. They're just going to slug you because you're right there and they want you to stop, and so you kind of have to remember those things. It's like, okay, what are you doing, and how might they react? Confusion. Use, activities that are meaningful. If you can find functional things, they do a lot better. Versus just because we, we used to just, we could stack the cones, and that works, if you need somebody to be able to open their hand and do whatever. But we found if you're trying to get them an activity, if you want them to do sitting balance and you need them to keep them busy, we have this whole bucket of brightly colored washcloths. All these little old ladies will fold these washcloths all day long. They love it. Makes much more sense. Now, if I gave them, a piece of paper and said fold it, they'd be like, okay, well, what am I going to do that for? And to do it over. So you really want to think we do much more of our activities are much more functional. We have, everything from, a little kitchen setup, sorting out, junk drawers, activities. The gentlemen, we have a couple of building activities that we do, and they have, like pictures to follow. So the more complex, that they can tolerate, they have to follow the picture, and they use like those PVC pipes and make little pipe trees and stuff. That makes more sense to them. And you find out what your patient likes, and you'll get a little more buy-in. We're always transforming. It's like, oh, and a big one is, it's like, okay, can you help me do this? Especially those folks that don't have a whole lot of physical deficits, maybe some balance, a little bit of, but you need their attention and concentration. We have this bookshelf full of books, and we're like, oh, there's all these books over here. Can you come put them away for me? Can you help me with this? And they feel much more engaged. Again, attention and concentration. If you've got somebody who's got a short attention and concentration issues, then you want to have shorter sessions. Maybe an hour is too much. Might be all right, but then you got to switch things up a lot so that they are not, because they won't attend that long to one task. You need to be flexible. Their plan might not be your plan. So you might come in with your little list of things that, oh, this is what we're going to work on. Well, guess what? They're not. We did that, they're like, oh, this is going to take them a while. I've got this peg thing they're going to sit and do. Boom, they're done with it in 30 seconds. You're like, okay, now what am I going to do? So you got to kind of, roll with it a little bit with these folks. They can challenge you. But that's what makes it kind of fun. It's not the same thing every day. Let's talk a little bit about a few outcome measures that I know I use and stuff, and I'm sure you'll see many more of them. The FIM is the one we have to do. That's just, there's not anything we at acute rehab, that's how we rate everybody. We do it at the beginning of their stay, the end of the stay, and now we're doing it kind of on a weekly basis, just to kind of track progress. But it has its limitations. Berg balance is one we use a lot. 10-minute walking speed I didn't put in there. The tug, time up and go, Tonetti, the BESS, which is a balanced error scale system that they use for, it's a very simple test that they'll use for post-concussive. And they're actually doing it out on, a lot of the ATCs are doing it right out on the field. It's something they can do quick. They can bring it right with them, and boom, it's done. COMBI stands for the Center of Outcome Measures in Brain Injury. So there's the website, and you can go on there, and they have 37 different outcome measures that are used for brain injury. But it's things that speech would use, neuropsych, it covers a lot of disciplines. But there was 14 institutions that collaborated and came out with these, put together this list. And it's really nice to go into, you go log on and you can just look through them all and be like, oh, what am I looking for? Is there something that will help me test something? And one of the ones that we came up that we use a lot now is the agitated behavior scale. So if you've got that patient who is agitated or restless or whatever, and you want a way to define, has there been any progress, any change in that behavior, this is a nice scale. It's 12 points to it. And they look at everything from, are they restless, trying to leave the room, are they talking in loud voices, things like that. And it's, if you are looking for ways to, if you've got a patient who you're just kind of going through the motions when it comes to keeping them busy, you're walking them a little, you're doing some exercise, you're doing, but you're like, okay, how am I going to show any progress? How are these folks changing? That's a nice way to, that's one piece of outcome measure that you can say, oh, well, this is why they're stuck at this point. And they divide it up for you nicely. The coma, near coma scale, if you're working with really low level patients. There's a multiple errands test. It's kind of a cool test. There's, if you look it up, there's a whole bunch of different facilities have made it for themselves. It's not a test that you can use across facilities. It's not something you would use like in a research project, but you use it within your own setting. And it's everything from like, they give you like these little errands to run, and some of them are paper or pencil, some of them and stuff, so that they have to do these activities, and it can kind of show you how they put together some of that problem solving, some of that thought organization. The MOCA is a cognitive assessment. Our OTs do that. I've done it on occasion if I just want to see where they're at cognitively. It's kind of a down and dirty, easy way to get a cognitive scale number if you're not working with a team. We just don't do it a whole lot because the OTs are going to do it, or speech is going to do it for me. Rancho scale, I think everybody's familiar with. Not something we use a whole lot. It's very speech driven when you look at what's in there, so it doesn't really tell me a whole lot. I mean, if they tell me they're at a Rancho 4, I know they're agitated. If they're at a 5, I know they're not agitated anymore. And so if they're 2, I know they're pretty low level. But past that, the rest of it doesn't really apply to anything to do with their physical condition or their abilities. So I don't use that a whole lot. The modified Ashworth, obviously we're going to use that to measure their tone, just to see how that's changing and how that's impacting them. A little bit about the review in the literature. Mr. Bland, I'm sure it was Dr. Bland, did a systematic review of the literature to look at the effectiveness of physical therapy for improving gait and balance in ambulatory individuals with traumatic brain injuries. So he looked at all these sites, 980 citations from January 1980 to December of 2009. And only 20 really met the criteria for all. And what he found was there was pretty limited evidence, obviously due to the small sample size, and variable interventions, and there lacked any standardization. Well, that's kind of brain injury in a nutshell. You can't, they're pretty hard to clump together when it comes to looking at a physical therapy, what intervention per se might work. We've been able to, I use a lot more of what comes from the stroke literature because they're a little more compact. They're what's going on with them. You can kind of at least see, because you see, enough left hemis from certain areas. You're like, okay, you kind of got an idea of what works, what doesn't. There's also, you can go and you'll see this on this website, or I found this also through APTA. It's the evidence-based review of moderate to severe acquired brain injuries. So what they did was, up in Canada, over 9 years, they reviewed over 30,000 titles and 6,000 abstracts. Not a job I'd really want. Doesn't sound awful. Sarah, I think, would love it. If she could just sit there, she could do that for a while. I don't know if she could do it for 9 years, but that's a bit high. But they just looked at titles, and then they looked at the 6,000 abstracts that fit. So they wanted to look at to see what related interventions they were using for acquired brain injury. So I pulled together a few of just sort of the findings on motor and sensory. You know, they broke it down as to motor and sensory impairment, vestibular issues. So they broke it down into different issues. So it's a nice site to go to if you're looking for something specific when it comes to brain injury. So they looked at exercise interventions post acquired brain injury. And one of the things through looking, they found that partial body weight supported gait training is not better than conventional gait training for improving ambulation, mobility, or balance. Specific training interventions post-brain injury are effective. And exercise help improve mood, overall general health, health promotion, and self-esteem. You know, that's a pretty generic, I mean, that's, I think, exercise in general. But it fits with the brain injury population as well. So you don't have to have a lot of fancy equipment. If you have it and you want to use it, I mean, it's a nice adjunct. But don't feel like it's like, oh, I'm not, you know, being able to give my patients everything they need because I don't have it. And then they looked at, I pulled out the vestibular. One of the things they had in aerobic dance, slide, and step programs improved balance and coordination with post-brain injury patients, which makes sense. And then a vestibular program is an effective method for improving symptoms of vertigo in patients following a traumatic brain injury. And we're seeing that a lot. But that's an easy way to find the evidence of what you might be looking for. It's already done. And they looked at a lot of them, so why reinvent the wheel? How are we doing? Oh, not bad. Okay, I'm going to talk just a little bit about concussions. That can be a day to 2 day long topic. There's a lot going on with concussions these days just because of the athletes, all the way from the little kids to the pro athletes. So again, a concussion is a mild brain injury. It's usually not associated with structural damage, so you're not going to see anything on CT or X-ray. You might see, you know, like skull fracture, but most of the times when you have a skull fracture, they may not say that it's a concussion. It's a metabolic injury. There is a whole cascade of events that occur when you've had a concussion at that neurophysiological level, and so that's what's really going on. There's some pathophysiological changes that are evident. They've shown them, they proved them. But there's little evidence of permanent cell damage, so that's the good news, that most of this is not long-term. Now, there are people with post-concussive syndromes that have long-term issues, but some of what's going on pathophysiologically, they recover. McRae, he does a ton of work on concussions and a lot with athletes. He's kind of one of the big gurus that you'll see if you do any concussion, if you take a class on concussion. So what his evidence showed was that the bulk of the evidence says that 5 to 7 days after concussion, the brain is exhibiting this abnormal metabolic activity. 7 to 30 days after, you're getting a normalization of those changes. And most of the symptoms should have resolved. And by 45 days, all the symptoms should have resolved. But it's that first 45 days that's what you may be treating.
How is he measuring that metabolic abnormality?
Blood tests.
Oh.
Yeah, it's done through a blood test that they can figure out that they've been able to look at. It's the chemical changes, and I apologize, I didn't go that deep into this.
It'd be like glutamate levels?
Yeah.
Well, just the blood test is good enough.
Yeah.
I just was curious. I'm like, okay, so
how would they know that? Yes,
yeah.
Exactly.
All.
Yeah, it is. It's
yeah,
all.
If it doesn't show up on CT and MRI.
Right.
Yeah.
Mm-hmm. Right. It's certain enzymes in the brain and stuff that they are able to track. Yeah, it's quite amazing. And I don't know that it's not something that they look at, like if you had a concussion that you're going to do the blood test to see, but what they've been able to say is that's why there's not like cell damage at the time, like a traumatic brain injury, where that it's just because it's that fleeting thing that there's no tissue damage, but yet because of the chemical enzyme issues.
It's like an inflammatory response.
Yes, yeah, very similar. Symptoms of concussion, again, same kind of categories. Biggest one that's different is sleep. A lot of sleep disturbances in patients who've had concussions. But you're going to still get some of the cognitive, physical, and emotional.
Long-term sleep disturbances?
If they've had a significant post-concussive, yes, where they've had, and usually I think some of those long-term you're going to see where you've had multiple concussions. I think the traditional, basic concussion that, things kind of go away and, that 30 to 45 days, not so much. But it's the biggest issue, one of the biggest issues with concussions is if your brain hasn't healed from the first, when you've had the second, there is a huge cumulative effect. Once you've healed from the first, the second one, if you had a second one, not as severe. Because it's like you're starting over, you get to kind of hit the rewind button. But if you haven't, so that's why some of the kids with, playing soccer or football or whatever, they've had these mild concussions and they don't tell anybody or they don't want anybody to know, then they have a second one on top of it. And that's what kind of gets everything escalating and a lot harder to treat because that whole enzyme thing, then you just re-inflame it. And once you hurt something that's already been hurt, obviously you got a lot more issues. Some of the treatment that they're looking at for that is, I don't know if you've heard about the impact testing. A lot of the kids do it in junior high and high school. It's a great baseline. It's a hard test. I took the test. We took it as a group. It is a hard test. I'm just like, whoa, how do you remember that? And stuff, but it's great that they have this baseline test. You haven't taken it. I'm going to make sure somebody gives it to you and you see. But it's just, there's a lot of, it's all that, they show green, but it's written red and you have to, they start flipping all that kind of stuff around. It's pretty interesting, but it moves pretty quickly. And so they give it to all the high school, they're supposed to, a lot of the high school kids, and to get a baseline. The problem is the high school kids are finding out that, they hear from the seniors, the juniors, or and the freshmen, they're like, yeah, kind of bomb it. Don't do so well. Because then when they make you take it, you don't look so far off. So there's a lot of those kind of issues that, because these kids want to go back and play the game, and it's all about the game to themselves.
Change the sequence of the testing, so they...
Well, it has nothing to do with, because it's pretty random, but it's like, it's one of those things that's like if you, it's like playing a game. You're like, okay, you can kind of pay a lot of attention to it to see if you can get top score. You can just kind of give it, whatever, minimal effort. And that's the problem. If they're not given, kind of their maximal effort, then you don't know what their true score is. And then what they do is they're going to go, once they've had a concussion, they're going to test again. And they're going to test, once or two times, depending on how far off they are from baseline, because they want to see how they do and as they get better. Vestibular therapy is a big one that these folks are going through. Medications for sleep and pain, for headache pain. And they have, because of lack of sleep and headache pain, they have a lot of mood disturbances and stuff. So very short, having issues with, going back to school. There's a lot of, if you read the current literature, things are up and down now, whether they want them back in school because they don't want them in sports, they want them resting, but yet, resting from school as well. Well, how long is too long? And so before they were like telling them to stay home as long as they were having symptoms. Now they seem to be backtracking on that and getting them back to school a little faster. They are trying to keep them off the video games, the phones, anything like that that's got like that hyperstimulation because that really affects them. Psychology and neurooptometry are the other two big things that they're looking at to help treat them. Your symptoms, anything headache, dizziness, a lot of visual and sound sensitivity. Things are too loud, things are too bright, they want the lights down. Balance. They may be able to walk fine, but, if these kids are, soccer players or any kind of thing, they can't do those kind of challenges. They can't stand on one foot. They can't stand in tandem. They can't stand with their eyes closed. Nausea is a big issue early on, but that seems to be better until you start playing with their balance, and then you can really get that, ramp that up. They're going to have some amnesia. Usually, maybe 4 to 8 hours before the event, they don't remember. You know, they remember going to school that day, but they don't remember going onto the field. So they never really encoded that memory, is why, before the concussion. Sleep disturbances, impairment in attention concentration is a big one. I mean, that's why these kids are having lots of issues in school, because they can't attend to it. And I mean, a lot of teenagers can't, their attention and concentration isn't their strong suit to begin with. And then some of them will have some confusion. So when McRae, he did a study in 2013, he looked at just under 800 high school athletes, and this is where he found his recovery time. You know, 21% only had it for a day. The majority, you know, 7 days or less. 1 week, about 12%, and then over a month, you know, just a little over, or just a little under 3%. So, you know, most of them, you know, kids are amazing. They heal pretty fast. Here are my references. And don't know, you know, you can't look and make sure they're all in exactly the right order of how you're supposed to do a reference list. So I'm not publishing this, so you can blame PowerPoint for that, because they don't like to change things around too easily. Questions? Oh, an hour right on the nose. Not bad.
So, Colleen, are you getting admissions to Mary and Joy with this whole high school traumatic?
We are in day rehab. We have a post-concussive institute, so to speak, and yeah, they go through day rehab. Most of those kids don't need to be hospital-based. I've had a couple, but more of them more college level, where they're, you know, yeah, falling down the stairs, you know, at a party or whatever. You know, I had some more where we've, and a lot of it's insurance-based. You know, whether they, you know, so they don't meet the medical criteria to be an inpatient acute rehab, but they go through our day rehab program, and which is really the place for them, because they need downtime. They need to be able to, you know, kind of acclimate back into, you know, sort of their society in a sense, but give them some skills and some, you know, treatment techniques to help with some of these issues.
So, do you treat them? Do you treat them in the first week when they're still having headaches and nausea? And
Generally not. Sometimes the ATCs, if they have an athletic trainer at wherever they're at, but usually they've got them pretty much on rest. We'll only treat them if they've got specific injuries, but usually they can't get in. They're not going to get into, and like they say, the literature shows most of it just goes away on their own. As long as, you know, you give them some, most of the emergency rooms, they're going to give them kind of literature that says, you know, this is what you can do, what you can't do. Not going back to sports, not going back, you know, until you're active or symptom-free. There's a whole chart on returning to play. You have to read. There's a lot of them out there, so depending on who subscribes to what, whether, and there's a couple of docs even in the area that look at a lot of those, that, you know, they have their parameters depending on what type of sporting activity they do, how much of a contact sport it is.
It's important for those that aren't getting that recovery in that week that they get the services they need. So it might not just be physical therapy. It might be neuropsych or a specialized vestibular therapist. So it's really important that we recognize the need.
Right, and that they, you know, and I think the emergency rooms are doing a better job, and so are the any of the athletic trainers that that, you know, making sure that these guys, you know, get, you know, that they get follow-up. And that's the big thing, is getting their follow-up. And if they need somebody that's, you know, specialized to see where, you know, what kind of symptoms they're still having, because they need the rest. The rest and the pain are the two big things. And if you can't get rid of that headache, pain, so that they can rest, really impacts their healing.
You talked about having your patients be in an upright or sitting position for about 3 to 6 hours. How does that go with them being agitated?
Well, here's the deal with the agitated patient. The agitated patient, I don't worry about as much, especially if they're very, you know, physically agitated. That, I call that free exercise. They're moving all the time, and they don't sit still long enough. So if they're agitated and it's not a safe position, then I'm not going to have them sitting up. Most of you know, what we've been able to do if they have a lot of, they're going to say, you know, they're pretty low level from a functional standpoint. They have no trunk control, no head control, but they've got one arm swinging, one leg swinging. Then what we're going to do is we're going to put them in like that tilt and space chair. We're going to get them in a chair that kind of holds them in place so they can still swing that arm, swing that leg. We can tilt them back if we need to, and tilt them forward. So they're still in a, like I said, in a 90-90 position. Versus being in bed, because even if they're in bed, they're thrashing around in bed, and that's just as big a problem. So we kind of look at it that way. So we get them, but we just want them somewhat upright, so they're not laying down, you know. And even if it's in a recliner chair, where, you know, every hour for 10 minutes you recline them back so that they're, you know, reclined, you know, 50, 60 degrees, that's fine. But then they sit back up, because we want to keep their sleep-wake cycle more normalized, stuff like that. So a big issue why a lot of those folks are agitated as well is because they're uncomfortable. Right. Something hurts. And it may be the tone that you can't do a whole lot about. It may be just their positioning, because, you know, they can't sit up straight, and so they're sitting on their butt funny, and that hurts. So we work on making sure that that's as comfortable as we can, and making sure that, you know, they have pain medication, and then they have like antispasmodic type medication, so that, you know, some of that tone might be decreased so that they're not so agitated. Yeah. But, you know, if you've got a guy who's, you know, walking and moving, I mean, those are the agitated patients that are the challenge, because I've got one right now who's just like, you know, he's ready to go home, and he's got his bag packed and sitting at the locked door, and you're like, okay, how do I get this guy? How do I treat him? Yeah. And yet, you know, yesterday I treated him. I got his bag, and he wanted his coat out of his bag, and it was a blanket. He tried to put this blanket on his head, and I'm like, yeah, that's not going to work so well. And all that was in there was a blanket, a shirt, and a pillow in his bag, but he was going to go home. So we work on, you know, doing things that aren't agitating to them, and stuff, but we keep them up as long as, you know, as much as we can. We're really lucky we have these enclosure beds. And so it looks like it's a regular hospital bed, and it's got this frame around it that's got a netting all the way around it that zippers up, and so that they can get in and out, and they have that freedom to move around in bed, so we're not tying them in, because that can really agitate them a lot. you know, take their movement away, and so that helps a lot. So we'll get them in bed, and then you know, and get them on if they get that tired that we have to lay them down. But yeah, it gives them some freedom.
Mm-hmm. You talked a lot about older adults with falls. Mm-hmm. Do you find it more that they may have, you know, like a traumatic brain injury, might be a stroke or a seizure that's creating the fall, or that the fall's happening and then they're finding more of that?
The fall's happening, right? Yeah, I mean, there'll be a few falls from a stroke, but then that's a stroke. Because usually they don't hit their head. Yeah. You know, it seems to be, you know, the big. Yeah, they usually hit their arm or break their hip. But yeah, usually it's the fall, and it's usually a balance issue. Yeah. They're getting up at night, you know, and they're just hovering on reserve, you know, just above that reserve line, that it's like, you know, they got up late. I had a lady who, God love her, her and her husband have separate rooms for sleeping issues, and she was going to his room, and it was during the middle of the day, but she made a turn, and the stairs were right in between it. Well, she thought she was going to go into his room while she went all the way down the stairs. And it was, you know, because of these falls, and being outside is a big one, you know, slipping and falling on the ice or anything. Their balance is the big issue. And it's, I mean, if they weren't on anticoagulants, the fall probably wouldn't have, you know, would have banged them up a bit, but wouldn't have caused the same kind of damage. But it's the anticoagulation issue that they're hitting their head, and it just takes a little hit. It's so little that it's kind of crazy. Because you may not even see, there doesn't have to even be a bruise and stuff. So it's mostly they're falling because of balance issues and strength issues and stuff that they probably should have been treated for before, or should have been.
More doctors being preemptive about that, cardiologists and.
I don't know. I don't think so.
It can be related to polypharmacy too.
Yes.
There's so many meds.
Yeah.
Yes.
I know with Medicare that they have to review their medication list more frequently now in their visits to identify and reducing that risk for falls. But how
I don't
much
know
the
that they're-
doctor's really
Right, and I think
taking that.
they
time
ask
to address
them,
that.
but I don't think the elderly are very good about telling you about it's what they do is, I mean, the elderly look at it, it's like, well, if they fell down, if you ask them, well, how many falls have you had? Well, if they didn't hit the ground, they don't count it. But the almost falls where somebody had to catch them, or they kind of fell and,
Hit the wall.
yeah, they didn't get
hallway wall.
hit the hallway wall, hit the bed, just had that stumble. And that's a question I try and ask more and more. It's like, you ask the ball question, but it's like, well, do you stumble very often?
Yeah.
Oh, yeah, when I, cross my dog, or oh, yeah, my family gave me a cane or a walker, but I don't like to use it, Then they've had some.
I find that so many of them are so terrified of being placed in the nursing home if they admit to falls
Right.
too many times. I find that a lot.
And I don't know that I think,
The
I mean-
cardiologist is not thinking about their falling.
Right.
They're
Or the
worried about
potential
the
for
risk.
falling, or their polypharmacy.
Right, if they take them off their AFib meds, then there's a risk for stroke.
Yeah.
You know what I mean?
Yeah.
So there's that
Right. But
risk-benefit
I don't
analysis
think,
that's really
I think they
hard to
could,
do.
maybe do a better job of saying, it's like, well, we're trying to prevent a stroke, but because you're on this, we need to be more vigilant about your balance and send them for more wellness stuff, for balance retraining and stuff like that, because I think a lot of them can really improve their balance. And even just, a sheet of hints, keep the lights on, wear shoes, get rid of your throw rugs, all those kind of things. Can make a big difference. And just getting any type of physical exercise, just going to the sitting exercise, group that, meets at the VFW or whatever. Anytime they're more, more active, their balance obviously is going to be better. So it's a big, and I find, there's patients that, I've been on Coumadin for 20 years. I'm like, 20 years? Geez Louise. What's the bigger, you get to a point, what's the bigger risk? And stuff. So, you want to put helmets on them all. Once a guy want AFib, and then you get a free helmet with your AFib, or with your Coumadin shot. But they don't want to do that. Not yet, anyway. They might, but. Any other questions? Well, thank you for coming.
Thank you.
Thank you, Colleen. And I just want to take a moment not only to thank Colleen, but also if you enjoyed this presentation and these Third Thursdays, to please take a moment just to send an email my way or to ipta@ipta.org, just so we can put out some testimonials on the website to promote this more, because we want to get the word out about Third Thursdays and just share the enthusiasm that people get by attending these and the CEs and whatnot that are offered.